Hey guys, how you doing? This is Chris Cruz. I'm a firefighter and paramedic with Albuquerque Fire Rescue and also part-time faculty here at CNM for the EMS program. So what I got for you guys today is a short presentation on, as the slide says, respiratory diseases, expansion disorders. I've broken it up into 3 parts. Each part is about 20 minutes long, and if you click on the notes for this slide, you'll see the outline where I break down, what we go over in each section and where you can find it. So in case that's useful to you. All right, so let's get started. Okay, so the lesson as a whole has a total of 6 learning objectives. First, we're just going to review real quick, what is hyperventilation? What exactly are we talking about? Then we're going to talk about how lung diseases can be broadly divided into 2 main categories, obstructive and restrictive. Then we're going to break down restrictive disorders into intrinsic and extrinsic based on basically which parts of the respiratory system are involved. Next, we're going to look at a particular subset of extrinsic restrictive diseases, the neurological subset. We'll go through some examples. We'll take a real brief look at the paint mnemonic, which is another way you can break down restrictive diseases based on, again, what part of the anatomy is involved. And then running throughout this will be a case study. All right, so here it is. You and your ALS partner are dispatched one evening to an in-district residential address for a 43-year-old male not feeling well, 26 alpha. Pretty brief. Those of you who have experience in the field already know that a lot of times this is all the information you get. So you arrive on scene, nothing jumps out, appears safe. You're waved in by a woman at the door. She identifies herself as the patient's wife. She brings you to the kitchen, and there's your patient seated at the table. Kind of a smaller guy, about 130 pounds, middle-aged as reported. He is looking at you, and your partner is making eye contact. Airway appears, patent and self-maintained. Breathing, at least visually, the assessment from the door, as we like to call it, not quite labored per se, but you know the way people breathe when they're tired, just kind of like a little heavy. That's the biggest thing that sticks out to you guys. This guy looks kind of tired. He's hunched over. Even his eyes, not quite puffy necessarily, but kind of a heavy lidded look. And then skin, ashen. Later on, you'll learn as your partner starts to do an assessment that his skin is additionally warm and dry. He's not cold or hot to the touch. He's not diaphoretic. So you and your partner introduce yourselves and you ask, how can we help you today? He responds, and he says, I just been sick kind of lately. I felt really weak, tired, and as weird as it sounds, guys, I feel like I can't even really focus my eyes. Everything's blurry. I don't really know what's going on. I feel heavy. My arms feel heavy. My legs, my chest. But I don't know. I thought maybe I just need some rest. I really wasn't going to call you guys, but more recently I've started having trouble keeping food in. So my wife finally convinced me to call. So your patient has kind of listed a handful of things that are going on. So of course you ask, sir, if you had to pick the one thing that's bothering you the most, what would it be? He again speaks up, and you're starting to notice the more he talks, there's something about him that sounds a little off, like maybe even slurred in his speech. He tells you, I just don't feel right. Everything's hard to do, and I can't eat now. I'm vomiting, and to be very frank with you guys, I've been having diarrhea too. So you guys decide to dive right into investigating this chief complaint. And I'll just say that, early on I was taught that the OPQRSTU assessment is a pain assessment, and even more specific than that, a chest pain assessment. Now, what I found as I've practiced is that I like to apply it as much and as often as I can because I feel like I get a wealth of information asking these same questions, whether or not I'm asking specifically about pain or not. So take that or leave that. If it works for you, great. It works for me. So, that being said, here is what your patient says. As far as when his symptoms started, they started just yesterday. Nothing makes it better or worse. If anything, he's getting worse, which is why he called. As far as how he feels, again, he's like, I'm just tired, I'm uncoordinated, I'm heavy, I got blurred vision, which I don't know if I'm so tired and I just need to sleep. But the thing is now, I can't even eat. So, as far as, does your complaint refer anywhere, radiate anywhere, not really applicable. Same goes for on a scale of 1 to 10. But for tea time, yeah, he says, I've been feeling off like this it's been going on for like 24 hours now. And it's never happened to him before. Now some sample history. Signs and symptoms as he's reported. It's weakness, visual disturbances, fatigue, also vomiting and diarrhea. Denies any allergies. His medications are testosterone and albuterol, PRN. Past medical history includes childhood asthma, also happens to be female to male transgender, which explains the testosterone. Last oral intake. So he says, um, well, I did have dinner last night, and it was meatloaf. Wife made meatloaf. I baked us some potatoes, and we had some canned beans and canned corn from her sister. My sister-in-law, she's just started getting into canning things, putting things in jars, and we had some of that from her. It was good. I don't know. Woke up this morning, had a little bit of an upset stomach, but I was hungry, so I had an egg burrito. That didn't go down so well. I had some diarrhea. So I tried to kind of tone it back for lunch. Figured chicken soup would be safe. Wasn't safe. Threw it up, so I haven't even eaten dinner tonight. Events HPI. As far as your patient's concerned, he's just told you the events. He doesn't really know why any of this is happening. He goes, it just sort of started to happen. And also, he denies having been recently exposed to anybody who's known to be ill. So here are your vitals. His LOC is that he's ANO times 4, GCS 15. Pulse is 90, strong regular at the radial. So technically within normal limits. You could argue it's a little elevated given that he's just sitting there, but he also did tell you that he's having GI disturbances, so most likely kind of a little dehydrated at least. O2 sat, 88% on room air, so that's something that you and your partner both kind of take note of. Likewise, BP 100 over 69, borderline hypotensive, but again, he has been vomiting and reports diarrhea. BGL is 60. Temp is 97.7, so he's afebrile. Pupils are equal and reactive at 3 millimeters, but your partner reports that they're a little sluggish. You guys put him on a 12 lead just because he has chest heaviness. You're not thinking cardiac, but it doesn't hurt. Looks unremarkable. NSR, no ectopy. Lung sounds are reported to be clear, but diminished all fields. And now it comes out, you're learning that when your partner asks your patient to take a deep breath so he can get these lung sounds, the patient has trouble with that, right? With that chest heaviness, he has trouble taking that deep breath. End title's kind of interesting. So he's 50. You guys remember normal range is 35 to 45, so he's a little high. He's retaining some CO2. His waveform is square, not shark fin. So a couple of things to think about. He's a little hypoxic. He's a little high CO2 or hypercarbic. I try not to say that word because I don't really know how to pronounce it. So he's hypoventilating, right? Either not breathing at an adequate rate or not moving enough volume of air. But the thing to note when you look at the fact that his waveform is square as opposed to shark fin is that the air he is moving is unobstructed, if that makes sense, right? The shark fin would indicate that there's something getting in the way of him exhaling whatever air he can get out. There's something in the way of him exhaling it all at once. So that CO2 is kind of let out in that gradual slope, which is how you get that shark fin. His square waveform, which is the normal waveform, he has a high number, but his waveform is normal, shows that when he exhales, the bit he gets out all comes out at once. So at least that much is normal. So given that he feels heavy, his pupils are a little sluggish, he's a little heavy-lidded, and really his speech, you're not quite sure, but it sounds kind of slurred. It doesn't hurt. He's not technically altered, right? ANO times 4, GCS is 15, but something is off. It doesn't hurt to do your Cincinnati stroke scale. Um, his face seems a little flaccid. He's got those droopy eyelids we mentioned, but he is symmetrical. Um, likewise, negative arm drift. His arms are weak, but they are equal. But the biggest thing, he does throw positive for the slurred speech, and you confirm with wife, yeah, this is not normal for him the way he's talking. Other findings on your physical assessment, you also note that his skin, his mucous membranes are pretty dry. But again, you're expecting that just because you're presuming a little bit of dehydration with his vomiting and diarrhea. But given his tummy troubles, so to speak, you do a quick examination of his abdomen and you notice it appears slightly distended. You ask, you seem kind of distended to me, sir. Is this how you normally are? He's like, no, it seems a little puffy to me. You also note that he is tender to palpation in all quadrants. All right, so just keep that patient in mind as we go through all of this. This is just a short slide on hypoventilation, and we basically just touched on it already, right? Um, what I really wanted to point out is that, you're not ventilating adequately, but it can be due either to inadequate rate or inadequate volume, or a combination of both. So like I was saying, lung diseases can be broken down into two main categories, obstructive and restrictive. And kind of the shortcut way I think about it is just obstructive impairs your ability to get your air out, and restrictive impairs your ability to get air in. So I guess this slide is a little repetitive, but again, just to drive it home, obstructive lung disease impairs exhalation, restrictive lung disease impairs inhalation. So how does obstructive lung disease impair your ability to get your air out? Usually we're talking about involvement of the smallest parts of your airways, right? Because a little bit of change in areas that are already small are going to drastically reduce your ability to move air through them, right? So let's talk about, say for example, reactive airway disease like asthma. You've got kind of like at least 3 different things going on, and they all do the same thing basically. You've got swelling of the smooth muscle in the bronchioles. You've got spasming of that same muscle, and you've got secretions. So all that put together, reduces the lumen of those small airways and impairs your ability to exhale. Secretions are the same problem with chronic bronchitis, right? One of the COPDs. Another COPD would be emphysema, and that's your alveoli losing their elasticity. So all of those, because they impair your ability to get your air out of all those small spaces, are obstructive diseases. So here's the examples I just mentioned, right? COPD, emphysema, chronic bronchitis, asthma, bronchiolitis, which is just, generic inflammation of the bronchioles. Cystic fibrosis also falls into this category because it causes secretions. So all of that about obstructive lung disorders is in contrast to restrictive lung disorders, right? So obstructive impairs your ability to get your air out. Restrictive impairs your ability to get your air in, which is why they're also known as the expansion disorders. Cause difficulty inhaling, usually because of thoracic bellows pathology. Not always, though. But that's what this lesson is mostly about. It's about these restrictive or expansion disorders that impair your ability to get your air in. So restrictive disorders being expansion disorders, then by definition, reduce or restrict your available lung volume. So that's how these disorders cause hypoventilation, by reducing your volume, not your rate. You could try to compensate by increasing your rate, but we're really talking about lung volume here. And these disorders can be further broken down into intrinsic and extrinsic restrictive disorders based on which part of your respiratory anatomy is involved. So what do we mean when we talk about intrinsic expansion disorders? What we're talking about is the involvement of the lung parenchyma itself, the soft, squishy, pink parts of your lungs, right? involved in gas exchange. So we're excluding the vasculature, and we're excluding the large um, cartilaginous, right, airways. We're talking about the alveoli, they're involved in gas exchange, and some people also include the respiratory bronchioles. So I know this particular slide can be a little confusing because it talks about inflammation. It talks about, the airspace is filling up with things, and so that sounds like an obstructive process, right? Um, Towards the end of the presentation, we'll talk a little bit about how there is overlap. There absolutely can be overlap. But what I want you to take away from this is that when we're talking about intrinsic lung disease, we're talking about when that inflammation causes scarring, which then stiffens the soft tissue, and now it's no longer as soft as it's supposed to be, so you can't expand it the way you're supposed to be. And in that sense, it's restrictive. Here's some examples of lung diseases that are considered intrinsic restrictive diseases, including that sarcoidosis. And again, so you get this inflamed tissue, they call them granulomas. Just on the surface, it might seem like, well, if I have inflamed tissue that's swollen, that's more of an obstructive process. But what you guys will see, hopefully, in some of these images coming up, is that really these granulomas interfere. It's almost like you form a web, and it interferes with the lung tissue's ability to expand and contract the way it's supposed to. So here's a CAT scan image of a patient with sarcoidosis, and the view here is we are at the feet looking up through the body towards the head. Patient's right is to our left. Patient's left is to our right. You can see the mass there. That would be the heart, but you look at the lungs, and all those bright spots are that web of granulomas that I was talking about. So last few examples, pulmonary fibrosis is just kind of a generic term that captures any disease, which causes, again, the tissues of that lung parenchyma to become thick, stiff, and scarred, so it can't expand the way it needs to. And then any lobectomy or pneumonectomy, any kind of lung cancer surgery, because obviously once you get in there and do surgery, you're going to have scarring and stiffness as well. So here's an x-ray image of a patient with pulmonary fibrosis. All of that lung space there should be black. It should be clear, but you can see, it almost looks like cotton candy, all that white stuff. And that's the scarred, thickened tissue. Another view of a patient with pulmonary fibrosis. I think this is probably another CT, so same perspective as our last one. From the feet, patient's right to our left. That should all be black in the lungs, and instead you see a lot of those white nodules. So that's the fibrosis. This one's a little more of an extreme case. You can see a lot more of that white fibrous tissue. And again, just imagine if all of that represents tissue that can't really expand, that greatly reduces your capacity to take a deep breath, to get adequate volume. And last one, again, even more advanced, at least looks to me. I'm by no means an x-ray tech, but I think you can look at this and see that there's a lot of at least translucent, if not completely opaque tissue where it should be clear. So all of that is stiff and scarred and can't move, so it reduces your volume. So how will these patients present? Honestly, much like any patient who, for whatever reason, is hypoventilating, right? So the big one, shortness of breath, progressive exertional dyspnea. If they are coughing, it should be dry for the most part, because again, we're not talking about secretions per se. We're talking about stiffening and scarring and the inability to just expand your lungs. But you might have a productive cough. It's just a lot less common. If your patient has a lot of damage to those alveoli, they might present with some bloody sputum. They might also wheeze. Wheezing shouldn't be that common because it's not necessarily a narrowing or inflammation of those small airways. It's just a stiffening of all of that soft tissue. And then you may get some chest wall pain as well. So when I was putting these slides together, the information on this slide was a little confusing to me at first because it talks about what lung sounds you can expect to find. I read the word crackles. I was like, to me, that's fluids, and I'm not expecting to find fluids for the most part with these. Same goes for rhonchi. I think of rhonchi as coarse wheezes, and we just talked about how wheezes should be uncommon. But what I realized, the key here is that these are coarse sounds. So to me, the way I think about it that makes sense is, if we're talking about a stiffening of tissue that's supposed to be pliable, then trying to move that tissue to move your air in and out, I could see how, moving tissue that's stiff, that's not supposed to be stiff, would result in coarse sounds. So maybe that's the Velcro part of Velcro crackles. They're not crackly because a fluid, it's not a bubbling of fluid, it's crackles because stuff is crackling, right? Because it's stiff. Um, Same thing for the rhonchi. You're not hearing wheezes necessarily, like asthmatic wheezes. You're not hearing the whistling of small airways that have been made even smaller. But maybe you're hearing this whistling going through stiffened tissue that should be soft. So that's how it makes sense to me. So if your patient lives with these conditions, then you're going to find the kinds of things you would find with anyone who has a chronic respiratory condition, who is chronically hypoventilating and hypoxic. You get a little bit of cyanosis at rest, and you may even see some digital clubbing. So here's just a little picture of clubbing for those of you who haven't seen it yet. You could see the swelling at the fingertips to where they look like little paddles. You can see the rounding of the fingernails, and of course the bluish discoloration because of the chronic hypoperfusion and hypoxia. This concludes the end of part 1.